A patient presents with advanced immunosuppression and a sudden onset of focal neurological deficits. The MRI reveals multiple ring-enhancing lesions. You have two main suspects, toxoplasmosis and primary CNS lymphoma. One requires immediate medical treatment. The other may need a biopsy or chemotherapy according to instruction of his or her doctor. The clock is ticking. Do you know which clues will save your patient from an unnecessary surgery? Differentiating these two is a high-stakes game of spot the difference. Today we're going to walk through the detective's checklist to separate these two mimics once and for all. Clue number 1. Geography. Toxoplasmosis is often a multicentric traveler, preferring the basal ganglia and corticomedullary junction. Lymphoma, while it can be multiple, is frequently solitary and has a unique preference for hugging the subependymal surfaces or crossing the corpus callosum. Look for the smoking gun. The eccentric target sign, a small nodule of enhancement along the wall of a ring, is highly specific for toxo. On the other hand, if you see solid, homogeneous enhancement that disappears after a few doses of steroids, you're looking at a ghost tumor, classic lymphoma.
When the morphology is a draw, we turn to the physiology. MR Spectroscopy showing high choline and high lipids, lactate? Think lymphoma. But the real tiebreaker? Perfusion. Lymphoma is hypervascular, while toxo typically shows low RCBV. In the immunocompromised brain, the vessels tell the truth. Finally, we can conclude the differential diagnosis between toxoplasmosis versus lymphoma in cases of immunosuppressive patient as follow: restricted diffusion, increased relative cerebral blood volume, increased choline and increased thallium uptake in case of lymphoma, while in case of toxoplasmosis, it shows the reverse.